thank you for the course organizers for picking my case and for having this lovely course. It's my first time here, so it's been excellent. My case is, it's just a tabby. What could possibly go wrong? So the case is an 83-year-old female with critical aortic stenosis. She'd had increasing gradients for years. Mean was now 74. She was a bicuspid valve. She also had moderate aortic root and ascending aortic dilatation, so she also had associated aortopathy. She was active, still swimming, but complained of a bit more fatigue and some mild shortness of breath, lots of PVCs on her Holter. She's primary caregiver for her husband with dementia. So we thought, let's proceed with this and see if we can do a tabby. Her CT showed great femoral sizing, annular area that was within range, large aortic sinuses, coronaries that were both a little bit low, but with those aortic sinuses we weren't particularly concerned. It also was consistent with a bicuspid valve and a dilated ascending aorta. So we had selected, does it play better up there than it does on my screen? Can you just replay that for me? So this is our three-cusp view. We decided to go with an Evolut 34 valve in her, and that's partially because we'd had a complication in a bicuspid valve tabby about a month before. We'd actually had an annular rupture in a high calcium score bicuspid valve. So in this patient, we thought we'd use a self-expanding valve, retrievable because of low coronary heights. So this is the Evolut R34. And at the upper edge on the left cusp there, we are barely catching it. In fact, we were not confident. We tried 4 different deployments with it, and each time it would actually pop up into the aorta and we wouldn't catch on the left coronary side, despite starting deeper and deeper, and we were quite asymmetric, quite low on the other side. So after 4 attempts and it popping up repeatedly, despite using pacing, despite using everything else, we decided to switch to a Sapien valve. So we selected a Sapien 29. We're happy with our positioning. We're going up all the way on our Sapien 29. She's hemodynamically stable. We're thrilled. That took us 2 minutes compared to the 20 that we spent trying 4 attempts on the Evolut, and we think we're great. Until right now.
Try that again.
I also have it in another view. So, does anyone see the abnormality? Yeah. So, if you can play it one more time. So you can see it right there.
Can we go back to your previous view before the valve?
That may have been the injection.
Was the injection that caused it?
I don't know.
Can we go back?
Let's just play this.
Play this.
Was it here or no? Or no? Can you do it before this view, like just the position? It was for sure related to the deployment.
We only saw it. So that's the question. We only saw it after the deployment. But I've looked at these videos a lot, and there is something there before. So at the time, because we saw it just after deployment, we assumed it was due to deployment. But in review of the videos, there was actually something there before. Here's our really obvious picture, in case we weren't sure the first time. It's definitely there. So she is hemodynamically stable. Her radials are equal. Her pedals are fine. She's absolutely stable. She has nothing except a great big aortic dissection. So we actually...
It's nothing except a great big aortic dissection now.
Yes.
Yeah.
So we actually take her off the table because we wanted to talk to her family, because she was hemodynamically stable and wasn't having any sequelae. We had the OR ready, but we wanted to talk to the patient's family, and we did a CT, which I'll play a few times because it's a little quick, and but you see it all the way down. So by the time she gets to CT, she no longer has a right radial pulse. By the time she gets out of CT, she no longer has a right pedal pulse. So we discuss with the family, and we take her back to the OR. I hope this will play. This This is our intraoperative video. This is actually what a TAVI valve looked like inside the aorta, since it's not very often that we actually see what it looks like. When we actually went to surgery and had her open, and this is Dr. Peterson, we actually found the dissection is above the sapien frame. It is about half a centimeter actually above the sapien frame. So it's unlikely to be related to the actual deployment of the sapien, whether it was from the multiple pop-ups of the evolute or whether it was from the injection. She did have preceding aortopathy that was involved as well. We knew that going forward.
Doing Medtronic?
That's what we thought, was that it was probably from the multiple aortic pop-ups of the evolute before, because we kept not being able to catch on the left coronary side. It kept coming aortic. We tried pacing, we tried everything to stabilize her blood pressure, but we were never able to catch.
How'd you do?
So she actually did well. So we actually kept the sapien valve in place. We repaired and replaced the ascending aorta. We kept the sapien valve in place because it was functioning well and the dissection was above. This is her post-CT, which does show that, of course, she still has a persistent descending dissection flap, but she was perfusing everything. She had radial pulses back, she had pedal pulses back. She was out of the hospital 10 days later, which also probably points to the fact that she was a low enough risk patient that from the start we probably could have also just done an open surgery in her. Although she's 83, she had social reasons we wanted to do it this way. So TAVI and bicuspid valves, they've been excluded from all the trials. They have larger annulus, they often didn't fit the valves, leaflet asymmetry, higher calcium scores, asymmetrical calcification. All of these were thought and do put people at higher risk of annular rupture or valve embolization or dissection. There is some registry data on these, which actually showed with the early generation devices there was definitely a difference in outcomes with bicuspid valves versus tricuspid. The newer generation devices, we don't see the same signal. They've gotten a lot better. There's much less paravalvular leak. There's no significant there. Second valve implantation is improved, so is conversion to surgery. Overall, the mortality actually doesn't end up being a statistically significant difference, which would lean towards being able to do bicuspid valves safely. There is this data from 2011, which is what happens if you do convert to surgery. It's low numbers in the STS data. The conversion to surgery in 2016 was 1.3%, and the most recent data, I think it's 0.5 that you need to convert to surgery. But if you did go to surgery, you died. Your 30-day mortality was 52%,